Our next speaker will be Amy Lucas. She's a clinical specialist here at Carilion, and her topic is pulling sepsis together. When the pieces fit, the patient gets better.
So my name is Amy Lucas, and I am the medical clinical nurse specialist, and I wear several hats now, but the hat that I'm wearing today is of the co-chair of the sepsis committee. And so this poster was actually created by several members of the sepsis committee, so I can't take the full ownership of this. So that's where you get Gary Meadows, Susan Blankenship, Teresa Jones, Connie Kirby, and Corey Goodwin got together to make this poster. My other disclaimer is that anything that we're doing, we have to give credit to the entire committee, because nobody could do this alone. Nobody's a lone ranger here, so kind of give props to my entire group here. Sepsis, I hope you guys know, is a very complex problem. It's got a lot of signs and symptoms, and sometimes it progresses very rapidly from a systemic inflammatory response to an infection to multi-organ dysfunction syndrome and death. And it's hard to gauge when you start seeing someone who's looking a little septic, whether they're going to be one of those people that rapidly progress or whether they're going to be somebody who's going to give you enough time to decide what's going on. It is a prevalent problem, it is an expensive problem, and it is a deadly problem. So when we talk about prevalence, we do mean prevalence. At Run It Memorial last year, we discharged over 2,000 patients who had had a diagnosis of sepsis. Now, this is any diagnosis of sepsis, but this is a lot of people. And so what you're looking at here is how many we discharged each month that had sepsis. Now, out of that group, over 1,000 were ultimately diagnosed with either severe sepsis or septic shock. And for coding purposes, septic shock is considered a type of severe sepsis. The reason that we are interested in that is because when you break it up, those people who have severe sepsis or septic shock are the ones who are more likely to die. They are the sicker ones at this point, they have some sort of an organ dysfunction, hypoperfusion, elevated lactic acid. They're sicker than just the systemic inflammatory response. Now they have organ involvement. These people also stay in the hospital longer. So a lot of the initiatives that you're hearing about through the Surviving Sepsis campaign and some of the other groups focus on severe sepsis, and that is because of the higher mortalities, the higher length of stays, the worse outcomes. That doesn't mean that you should ignore people in the sepsis arena, because the earlier you catch someone, the earlier you start treating them, the less likely they are to progress down the sepsis pathway. Now, it's kind of a good news, bad news situation. We have lots of sepsis, but the majority of the sepsis that we have did not start in the hospital. The majority of people that have sepsis in this hospital were admitted with it. The green slice, the not present on admission slice, they are the ones who developed their sepsis in-house. The rest of these patients developed it and then were admitted with it. And as you can see, the red slice, the largest slice, are those that came into the emergency department with their sepsis present on admission. So that's where we decided to focus first on the emergency department. Other things that we determined as we were trying to clarify the problem, define the problem, see what was going on, we knew that if you had severe sepsis, if it was present on admission, if you came into the emergency department, we knew that the majority of these people were going to the ICU immediately after leaving the ED. So that's the blue slice. The other thing that we determined is that those that did not go to the ICU right away, a large number were actually being upgraded within the first 12 to 24 hours. And so we really intend on getting people to the correct level of care to begin with. The people who had to be upgraded tended to have the longer length of stays and the higher mortalities. So we had a sepsis alert process. The emergency room started a process in March of 2013. And so that involves sepsis screening during triage. So they are asking patients questions, trying to determine if their signs and symptoms could be related to an infection. They're looking for surge, and they were looking for a few things other than just surge. You know, surge are not very specific. They're looking at heart rate, temperature, respiratory rate, white blood cell count. They also added in altered mental status and blood pressure to that as well. Based on the results of that screening, they would draw labs, including a point-of-care lactic acid. And the reason the lactic acid is important is because even if you're normotensive and don't seem to have a lot of other signs and symptoms, an elevated lactic acid in the presence of an infection could indicate that you are in severe sepsis, and there is some literature that would argue that that is septic shock. So The prior process, based on those criteria, would call a sepsis alert if your lactic acid was greater than 4. The people that received this alert, other than myself and a few other people on the committee, were the pharmacy, who would prioritize the antibiotics and would actually go to the bedside to help hang antibiotics and fluids. The transfer center, who would try to prioritize an ICU bed, and then the nurses in the emergency department, who would prioritize administering the antibiotics and fluids and whatever else that the doctor ordered. So when we looked at this, we found that the sepsis alert patients did trend toward a shorter hospital length of stay. They trended toward a shorter emergency department length of stay, and they tended to have earlier antibiotics. The problem was that we only called 37 sepsis alerts in the entire 2014 year. Now, our target group of patients was severe sepsis patients, and if you'll remember, we discharged over 1,000 severe sepsis patients from this hospital last year. If we took even 60% of those, assuming those came in through the emergency department, that would be 700 patients. So we were way undercalling sepsis alerts. Now that would be okay if I could tell you that every severe sepsis patient got the same level of care in the emergency department. Unfortunately, the severe sepsis patients' average time to antibiotics ranged anywhere from just under 4 hours to almost 6 hours on average. That's from arrival to the emergency department. Anyone who has listened to me talk before knows that one of the things proven to help these patients the most is early identification, early appropriate antibiotic administration, and then monitoring them carefully to support them hemodynamically. So these patients, even without calling sepsis alerts, they were not getting the care that they needed in the time frame that it needed to happen. So we had to take a step back and look at why they were not calling sepsis alerts. What were some of the problems that we were running into? One of the big problems in the emergency department was there was not a perceived benefit for calling a sepsis alert. Any other alert in this hospital, if you call an alert, it rings a bell, people come to help you. They called a sepsis alert in the emergency department and they were told, good job, give your antibiotics, we'll see you later. So we decided to work on that piece. Another piece that we noticed is that there's very little use of the sepsis order set in the emergency department. The sepsis order set was intended to give them an easy way to order appropriate antibiotics, appropriate fluids, appropriate labs, so sort of a one-shot, easy-to-use deal. And there wasn't very much use of it, even with revisions to make it easier to use and more straight to the point. We also noticed with the screening and the escalation that we needed some work on the nurse's triage screen. There were oftentimes patients who came in with what I would consider obvious signs and symptoms of an infection. The nurses were clicking, no, they don't have an infection, and would move on to their next task that they had to do in the triage process. So there's some work to do there. And then the ED staffing itself. We are asking the nurses to essentially treat these patients like ICU patients for a while, but they are staffed like a PCU. The normal emergency room staffing runs 4 nurses, 4 patients per every nurse. And so it's hard to do that. And I don't know how many of you guys spend much time in the emergency room. It's a very poorly controlled chaos. So it's very hard to do that level of attention to those patients with what they were given. So we did some revisions, we shook a bunch of trees, we chased people out of the bushes, and so here's some of the things that we've done. So they are still screening on triage. They're still looking for signs and symptoms of infection. We did change the questions a little bit. So instead of the question being, you ask your patient, do you have an infection? The question now says, does the patient have symptoms that are consistent with an infection, or does the patient think they have an infection? And that's in addition to asking if they've had a fever and have they been on antibiotics. They still draw labs, they're still drawing their chemistries, they're still drawing their blood counts, and they're still running point-of-care lactic acid if the patient looks like they could have an infection. Now when they call a sepsis alert, though, it can be called for any suspected severe sepsis patient. So if the lactic acid is elevated, if they're hypotensive, if they have lab abnormalities, that we've opened that a lot broader because we were missing a lot of patients. Other things that have changed. So in the prior process, the page would go out, pharmacy got the page, transfer center got the page, and that was pretty much it. In the current process, now the ED administration now knows when there's a sepsis alert in the emergency department. We didn't realize that they weren't on this page. There would be a sepsis alert and nobody would know it. So now the ED administration is on board, they come by, they offer to help. We also arrange for that patient to have a one-on-one nurse for at least the first hour after a sepsis alert is called. And then from there, they communicate back with the physician as to what the goals are and whether they think that patient could be part of a larger group or whether they still need to be a one-on-one patient. Pharmacy is still involved. Pharmacy still prioritizes the antibiotics. The antibiotics that are intended to give first are actually stocked down in their Pyxis, so they don't have to wait on that. The transfer center is still involved, but we've untied their hands a little bit. So they get the page, they know which ICUs these patients are targeted for, and those 2 ICUs also get the page. So that way, if they don't already have patients on the bed board to move, they can start looking to see if maybe they can triage somebody out. The clinical administrators are also involved. They got the page in the previous process, but they didn't really have a role. So they're rolled now. They go down to the emergency department. They check out to see if there's anything they can help out with, such, can they get an IV started? Do they need to help transport the patient someplace? And where they've really been able to help the most is going back upstairs and helping to move that ICU patient down to a PCU to get that room available a little bit sooner. The other thing that was really a win for us, we could not find a way feasibly to designate a physician to come to the emergency room and triage these patients and determine levels of care and write the admission orders. However, the admitting provider said, when you call me with this admission, let me know it's a sepsis alert. I will prioritize this patient, get down there to write orders within the first hour. And so that's a big win too. Making these bed decisions early on, in addition to having 2 ICUs trying to make a bed, has really decreased our length of stay in the emergency department. So we rolled out March 1st. As of April 27th, we had called 113 sepsis alerts, which is fantastic. Believe it or not, that's still not enough. Based on the first numbers, we could have called more. So the average time to first antibiotic from arrival in the emergency department is down to 96 minutes. Before we were counting hours, now we're counting minutes. And it's 23 minutes from the time that they call the alert. So that recognition has everything to do with it. So we're hoping for decreased hospital length of stay. The early numbers that I'm afraid to show you, just because it's the very first month, looked really good. There was decreased hospital length of stay, there was decreased ED length of stay. We're hoping for decreased mortality, because if we decrease the length of stay in 700 patients a year, we're going to improve the throughput, so we're hoping for better throughput. And sepsis will be a core measure. As of October, we're going to start collecting data on this, and so we should be in compliance with our core measures. It is still a work in progress. We told the staff in the emergency department that if you think this needs to be a sepsis alert, call the sepsis alert, and then we'll look at it and determine later if we need to clarify our process. So they are not only calling lots of alerts on people who may not be severe sepsis, but the ones who were really sick are getting better care. So now we're getting feedback from the ICUs that they're getting people who aren't as sick as they expected them to be, which is a good thing in a lot of ways, but so we're going to probably have to take a step back and sort of look at our admission process and make sure that we are getting people into the appropriate bed the first time without overusing ICU beds. We have only had 2 people that had to be upgraded since this process started, and those were early on in the process. So we don't want to swing the other way, so you'll see us sort of cautiously feeling out how to fix that. But stay tuned. The next steps are going to be to turn to the inpatient world and figure out how to do this on the inpatient side, because that's also a core measure. Does anybody have any questions?
Are you doing a concurrent financial impact study?
Yes.
Repeat the question, please.
She wanted to know if we were doing a concurrent financial impact study. And so finances is a big part of this. Not only are we looking at what we would save by dropping length of stay on these patients and changing ICU length of stays and ED length of stays, we're also looking at the resources used in the emergency department. We're trying to keep track of how often you're using that one-to-one nurse. Anybody else?